and get started. Okay. Okay, let's, yeah, I got everything on. Yes, good. Let's go ahead and get started here. We're going to take a look at the axial skeleton today. Last week we went through the skull, and I promise you I won't take near as much time and bore you as much as I did last week. But the axial skeleton is the vertical axis. It is everything lined up in a straight line. It is the vertebrae, all the vertebrae from the cervical vertebrae down to the tailbone or the coccyx. It includes the bones of the thoracic cage, the ribs, and the sternum, and the parts, the three parts of the sternum. And it shows you how we'll see today how the vertebrae all come together to allow the passage of the various nerves that lead into the spinal cord and come out from the spinal cord. So all we'll have left then is the appendicular skeleton, the arms and legs, hands and feet, fingers and toes. And as I've said several times, everything on the left side is the same as everything on the right side. The list I sent out last night to everybody gives you all the bones, gave you all the bones for the skull, plus all the processes, all the holes, the foramens and the fossas and like the mastoid process and things like that, and the sella turcica and all the different structures. I also sent you the list then for all the remaining structures for the axial skeleton and for the appendicular skeleton. So it sounds like a lot, and it is a lot, but it's not as overwhelming as it could be. As I was telling the class yesterday, how do you prepare for this test? Well, you do it a little bit at a time. You learn a little bit every night. You don't overwhelm yourself trying to do it all at once. You can't do it. You can't wait till the night before to take the test and do well. You got to spend some time, because the advantage of that is by taking your time to prepare for it. Thank you. You're going to end up doing well on it, and you're going to be able to carry that information with you. Because there's, regardless of what you're going into in some health profession, it's likely that you're going to need to know what these bones are and what they're called and where they're located. So, and this is the first time you're going to get that opportunity. And then right after that, we do the muscles. And so between the muscles and bones, you come out of lab with a pretty good idea of all the structures. And again, the muscles are going to be easier. There's only 60 muscles you have to know. And remember, they're the same on both sides. And a lot of them are named for the same bones they're on top of. So they're pretty straightforward. So it's not as painful as it might sound at first. If you don't do as well as you'd like on the first lab test, many people have historically done very well on the second test, because the second test is straightforward and the second test makes sense. I mean, who's going to care about mitosis in any kind of clinical setting? Hey, tell me, what do you think of prophase, huh? I mean,
it looks like this.
Thank you. Yes, yes.
So back to freshman science.
There you go. And I will tell you that while most of us in the natural science division are, I will admit, I'll be the first to admit, we're all a bunch of nerds. Even we don't talk about stuff like that. Dr. Grice and I don't say, hey, well, what about prophase? What do you think? Well, I like mitosis better. No, we don't. No, we don't. We're not quite that bad. So I will confess to reading labels on vegetable oil bottles to see what kind of trans fats or anything like that they got, but that's beside the point. So anyway, but bones and muscles are going to make sense. They're going to be relevant. There's something you're going to deal with. You know, depending on what you're going into, you're going to more than likely need to know what these body parts are. So that just, okay, enough trying to make a sale on it. Let's go on. Here we go. Let's get into the axial skeleton. So the axial skeleton. First thing we're going to see here is the sternum, the breastbone right here in the front. It has a very important role. It protects our heart. Our heart sets directly underneath the sternum. There's our sternum. It sets sort of tilted off to the side, pointed, the bottom of the heart is pointed towards our left hip. And it's almost directly underneath the sternum. If you've ever taken a CPR class, you know exactly where your sternum is located because you compress the sternum to get to compress the heart. We have 7 vertebrae here above the rib cage. These are called the cervical vertebrae. And frankly, most of your vertebrae are all going to look the same. Some are going to be bigger than others. I will tell you that I will not ask you to tell me what kind of vertebrae that is. You know, I wouldn't do that because I will tell you the 7th cervical vertebrae and the 1st thoracic vertebrae look exactly the same. How can you tell what they are? Because one, you know, it's like this is number 7 and this of cervical and this is number 1 of thoracic. They look the same. You'd have to start measuring things. What about the 12th thoracic vertebrae and the 1st lumbar? They look the same. So what's the point? You know, the point is that you know that these are, you know, these are vertebrae. Know the parts of the vertebrae. So if we have a skeleton like this, know that the ones above the rib cage are the cervical vertebrae. The important part about the cervical vertebrae is the first 2 bones. The first 2 bones are very important. The first 2 bones are what holds the head up and allows us to turn our head to the left and right. It forms, there's a little axis in there that allows us, our head to rotate around it so we can look to the left and right. So there's the cervical vertebrae. We have ribs. We have 12 pairs of ribs. We'll see shortly that not all of them are attached in the front and the back, but the ribs are there to protect our viscera inside the thoracic cage, the heart, the lungs, the airway, the esophagus, the great vessels, the aorta, and the vena cava. So we want to protect all that. And also it's protection for the spinal cord, which is inside the spinal column. So we have this very powerful bony structure here. It's probably the 2nd best protective portion of the body other than the skull and the spinal cord itself. You know, the spinal column protecting the spinal cord. Within our spinal column, you know, we have the cervical vertebrae, we have the thoracic vertebrae, we have the lumbar vertebrae, and we have a disc between each vertebrae. These are called the intervertebral discs. These discs are designed to cushion the movement of the vertebrae between each other. They function as shock absorbers. And if one of them, if the disc puts too much pressure on the pad can blow out. And we say we have a blown disc or a slipped disc, or your patient has to have fusion or something. It's a very painful condition for that to occur. There we see one of the lumbar vertebrae. So there's somewhere between 5 and 7 of the lumbar vertebrae. They're very large. They're at the bottom of the spinal column. They lead to 2 very large bones, the sacrum and the coccyx. You'll see the sacrum here. Oops, let me go back. I can't see it very well, but the sacrum is a fusion of 5 vertebrae at the bottom of the column. And then right below that is a very tiny little bone called the coccyx or the tailbone. And it doesn't do much except have attached muscles. So here are the ribs. Got them highlighted in red. For the true ribs, there are 7 pairs of true ribs. They are attached in the front to the sternum. They're attached in the back to the vertebrae. They are held in place in the front by hyaline cartilage. Got a rib model over here. If you can hand me that one, that one. Thank you. This is a model of our ribs. The ribs are not visible here because they attach to what we call the hyaline cartilage here, 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 and here. The first 7 pairs of ribs attach directly to the sternum. You can see here they're in red on this model, and I'll put it up here on the screen. Let's get this off. There we go. When it came out, it's almost like I planned it that way. This is the sternum right here. The first 7 sets of hyaline cartilage, 1, 2, 3, 4, 5, 6, and 7, attach the ribs to the sternum. The reason we have hyaline cartilage there is we need to have our ribs to be flexible. Between these bony ribs, and you can see them here on the skeleton, we have very thick bands of muscle between the ribs. And if you like eating ribs, that's what we eat. We eat the muscle between the ribs. I mean, if you like ribs, that's what you're eating. You're eating the muscles. We call it the intercostal muscles. But when they contract, they cause the rib cage to rise up. When they contract and the rib cage rises up, our lungs are glued to the inside of the chest wall. The chest wall rises when the ribs contract. The lungs inflate when those muscles contract. So when we take a breath, what we're doing is we are, the ribs rise, the muscles contract, the ribs are elevated, the chest wall expands, the lungs are glued to the inside of the chest wall, so the lungs expand, and we suck air in. And when we relax those muscles, then the ribs drop. Well, the chest wall drops, the ribs drop, and air goes out. That's the whole process of breathing. So we use those muscles all the time. They're called the intercostal muscles. The ribs are often called the costal bones. These are the muscles between the ribs, if you will. And so that's also the same muscles we like to eat when we eat ribs, so whether it's, pork or cow or whatever. So anyway, the first 7 pairs of ribs are the true ribs. They're held in place by 7 sets of hyaline cartilage. Hyaline cartilage is very flexible. Below that, we have an indirect connection. You'll notice here on this last set of hyaline cartilage, we have 1, 2, 3 connections. These 3 bands of cartilage connect to the 7th band here at 1, 2, 3, 4, 5, 6, number 7. These 3 connect indirectly. They are what we call the false ribs. And so the false ribs don't attach directly to the sternum, they attach indirectly. Now that still creates a problem because we're shy 2 ribs. Ribs number 11 and 12 are called the floating ribs. The floating ribs don't connect in the front. They are only attached to the spinal column in the back. So the first 7 are true. 8, 9, and 10 are false because they attach indirectly. And 11 and 12 are the floaters. They still protect us. 11 and 12 do offer a little bit of protection for our the very top of our kidneys, because our kidneys are up high here, very high, right below the diaphragm. And they get a little bit of protection from the floating ribs, not a lot. But, anything below the kidneys, they get nothing except, layers of fat. But these are the 12 sets of ribs for us. Their role is to protect the viscera inside the thoracic cage, the heart, the lungs, the heart and the lungs, the esophagus, the trachea, the aorta, and the vena cava, the large vessels, and to provide some protection to the spinal column. But their other role is to raise the rib cage when we breathe. The ribs are going, since the chest wall is attached to them, when the muscles contract, the ribs go up, the chest wall expands, the lungs are glued to the inside of the chest wall, the lungs get bigger and air rushes in, we take a breath. And then when we relax, we blow it out. We'll go into that in detail in AP2 when we talk about the respiratory system. But those are our ribs. Now, the ribs attach to the sternum. The sternum is our breastbone. You can feel where it's located, right in the middle of your chest. The most well-known feature that you can find is the xiphoid process, the pointy end of your sternum. If you've ever taken a CPR class, you know exactly where the xiphoid process is. That's your landmark. They always tell you, the instructor will always tell you to, you know, unless things have changed, since it's been a while since I've taken a CPR class, but you always used to say, come up, find the xiphoid process, come up 2 fingers width, and that's your hand position on the sternum to do compressions. Because if you compress the xiphoid process, you're going to stick it into the liver, which is never a good thing. Because the xiphoid process is the end of the sternum, and the diaphragm is right below the xiphoid process, and your liver is right below the diaphragm. Never a good thing to do, to stick holes in the liver. So anyway, there's your sternum. The xiphoid process is this pointy end here. They're not usually marked like this, and they usually don't show up in 3 different colors, but it's a great landmark. Because not only does it tell you that's the end of the sternum, it also tells you that's where the diaphragm starts, is right there. So, but this is our xiphoid. This is our sternum. It has three parts to it. The manubrium is the top. You can feel the manubrium if you stick your hand right here, sort of below where your, there's a little depression right here in the top of your chest. If you press against this flat area in here, you're pressing against the manubrium. That's the top of the sternum. The manubrium is very important because it's the location for articulation, meaning movement, with the 2 clavicles, your collarbones. These are your collarbones here and here. You can feel your collarbones if you put your hands on your shoulders and you feel this ridge, this round ridge right up along in here. Those are your clavicles, and the clavicles connect your shoulder to the sternum. They form like a hinge, if you will, because yeah.
So I was asking a question about, so your clavicle, I tore some of the ligaments that was holding it to my sternum, and so if you took the cartilage, it popped up a little. So was the cartilage going with it, or did it maybe break? I don't think it broke off or anything like that, but does the cartilage stretch with it? It
does, and it will grow back eventually. So the cartilage there, you know, it's very flexible. It is flexible, you know. It may not cause you any problems. It may cause you a problem later on. It's hard to say, but usually, do you have any trouble moving your shoulder?
Well, not so much now, but when I first did it, I couldn't really move at all.
Yeah. See, because the clavicle, your collarbone attaches at the sternum, and then it attaches here at the top of the shoulder, and it forms it forms half of your shoulder joint. And so if you damage that here, because that has to move when you move your arm.
I hit my shoulder on something and it went back, so it moved it that way. So yeah, I think that's why I had trouble.
Mm-hmm. But is it better now? Is it getting better?
Oh, yeah. It's
Okay,
mostly.
mostly.
From high school trying to play like my sports. It was harder to do because of that one arm.
Oh, yeah, yeah, I can imagine. So, because it's all, yeah, everything's interconnected. You know. You can still feel, you can feel where the sternum and the clavicle come together at the manubrium. We call that the clavicular notch up there. And let me mark this. Okay, so right there, there's the manubrium. There's two notches here. The top notch that you can sort of feel that little depression there is where the jugular veins duck in behind the sternum to go down towards the superior vena cava. The superior vena cava is a large vein that drains the upper third of our body. So everything from the head, the neck, the top of the shoulders, down to about here, ends up in the superior vena cava. It's a very short it's a short vein. It's a big vein, but it's short. It's only called superior because it's above. The inferior vena cava is a huge vein that drains the rest of our body, and it's about that big around, and it's long. It runs from here down to your abdomen, but it's called inferior because it's below the heart. Anyway, jugular veins come down behind this notch in the top of the sternum. Now, next to the jugular notch, we have the clavicular notches where you probably had your injury. Right here, you can feel the end of your clavicles where they sit right into that notch. You can feel the little bumps from the ends of the clavicles. And the clavicles, the collarbones, extend back then to your shoulder. And so if you hurt, if you damage the end here, it's going to affect how your shoulder functions too, because the clavicle helps to hold your shoulder together. Our shoulder is one of the most bizarre joints in our body because there's not much to it. We don't have a big socket or anything like we have in our leg. We just have a flat surface that the head of the humerus rubs up against. It's hard to, it doesn't dip into anything. So, and you can see that there's your clavicle right there coming out on either side of the top of the sternum. That green area is the manubrium, and the clavicle is coming off on each side of it. And then it articulates over here on our shoulder blade. Now, the body of the sternum is that area highlighted in blue. That sets directly over top of the heart, even though the heart's setting at an angle. The pointy end of the heart's pointed towards your left hip. We call it the apex, but I like to say pointy end because everybody knows what the pointy end is. So, and then we get to the xiphoid process below that. And so the xiphoid process, the pointy end of the sternum, we can all find that. So it's fairly easy to feel these parts. Okay. So that's our sternum, and this model shows you the hyaline cartilage present here. Doesn't have the ribs attached. Nice. Now so much for my ribs. Okay, now let's take a look at the vertebrae. So the first 7 vertebrae are the cervical vertebrae. They are protecting the spinal cord as it goes up into the brain or into the skull to connect to the brain. It is the top 2 vertebrae here, C1 and C2, that are probably the most significant for us because they're the ones that allow our head to turn. All the other vertebrae are pretty much fixed. I mean, our vertebrae have flexibility. I mean, we can bend over, we can twist and turn, but these 2 vertebrae, C1 and C2, allow us to turn our head like that, and to nod our head up and down too. None of the other vertebrae have that flexibility. So there's cervical. There are 12 thoracic vertebrae matched up by the 12 pairs of ribs that articulate on the back. Remember, articulate means where bones come together. and move against each other. There are the 7 or so lumbar vertebrae, very large vertebrae. The spinal cord actually ends somewhere about the second lumbar. It doesn't go all the way down. So if we look at our model of our skeleton here, we can see that somewhere, let's see, there's the last thoracic, so right about here is where the spinal cord stops, somewhere about lumbar 2. And below that, the cavity continues on down. It's still filled with cerebrospinal fluid. We have large nerves that extend down through there and come up through there. But this is where you can take a sample of spinal fluid with a spinal tap. You can inject an anesthetic like an epidural. You can feel fairly confident of examining, the spinal fluid or examining your patient without risk of sticking something sharp and pointy into the spinal cord, which is never a good idea. So, so it continues on down. The spinal nerve, the nerves feeding into the spinal cord are both coming in and going out, and they're going to continue down all the way into the sacrum, which is this bone that you'll see here at the bottom. There's the sacrum. The sacrum is 5 fused vertebrae, and it looks, you got a sacrum right in front of you there. Big one. There we go. Yes, that's it. This is a sacrum. This is life size. You notice it has a series of openings in here. Those are for the passageway of the various spinal nerves going into and out of the spinal cord. Go ahead. Let's pass that around. The thing about our nerves is that we've got 32 pairs of spinal nerves. So we have spinal nerves coming in on the left side and spinal nerves coming in on the right side. Now those nerves have both an input and an output side. We have an afferent and an efferent. So it looks something. So if you have here comes a spinal nerve, and it will split going into the spinal cord. And you have sensory on one side going in, and you have motor on the other side going out. And the same thing matches on the other side. Sensory in, and motor out on both sides. So you have 32 pairs of spinal nerves that are a combination of sensory and motor. And this all feeds into the spinal cord. And then on top of that, we have 12 pairs of cranial nerves that feed into and out of the brain. Some things like the optic nerve, the olfactory nerve, the acoustic auditory nerve, the hypoglossal nerve. These are a part of the 12 cranial nerves that come into and out of the brain. So, but as we'll see later on, yeah.
When they do spinal tap, they do that to check if you have meningitis.
Well,
they can use it, or they can do a spinal tap to check for meningitis.
Oh yeah, yeah. See what
Is that because it's connected to your brain?
No, what you're doing is they're looking to see in the fluid that surrounds the brain, the cerebrospinal fluid circulates around the brain and around your spinal column. It goes up and down. And if you take a sample of that fluid out, you can look for bacteria. You can look for, check to see is there a viruses present. It isn't just meningitis. I've got pictures in somewhere, I think in AP2 on the immune system, of anthrax bacteria that were detected in the spinal fluid through a spinal tap. So it's a great diagnostic tool. It's not pleasant, but
Definitely not.
yeah,
Don't
yeah,
recommend.
no. It's not something you do just, oh, I think I'll have a spinal tap today. No,
No,
it's uncomfortable, but it's a great way to examine, to get an idea of what's going on in the brain, because our brain doesn't do well for examinations. So,
I was just curious.
oh no, that's fine. That's great. I'm sorry you had to experience that, but
Granted, I was like kind of in and out of it, like unconscious, and
Mhm.
everything. So I'd wake up, and they'd be sticking the needle in there. I'd wake up, and they would already have. They drew like 3 different vials
Mhm.
from my spine, but luckily I'm alive. I'm still here. So.
That's good. Now, did you have meningitis?
Do what?
Did you have meningitis?
No, they don't know what was wrong with me, honestly.
Mm-hmm.
They said I was in kidney failure. They told me I was dehydrated, and they told me I had a urinary tract infection.
Okay.
So, but doing a spinal, they didn't, at the time, they didn't know what was wrong. So they
Mhm.
thought, okay, her symptoms, let's do a spinal tap just to make sure.
Well, they wanted to rule out
Yeah.
what it wasn't, and that's as painful as it is, it's one of the least invasive procedures to get a real handle on what's going on. See, the thing is that meningitis is so contagious, and every year we read about some school or college or university where meningitis runs rampant through the school for a couple of weeks, then it goes away. There's a lot of communicable diseases like that, and sometimes they're just treatable, but sometimes they get pretty serious too. So we're glad you're here. So okay, there's the sacrum, and below that is the coccyx, or the tailbone. This is 3 little vertebrae fused together. They don't do much except provide a place of attachment for muscles. Now, it's not unusual for that bone to break during childbirth. Because you're especially if you're telling your patient, okay, bear down, here comes another contraction, bear down, and so you're applying all this pressure, and it snaps. What do? Not much, because it's surrounded by muscles, and it's going to heal itself up anyway in a few weeks. You can't splint it. You can't. There's no reason for any kind of surgical intervention. It snaps and it grows back. Living bone does that. Lots of women that have given birth will have fractured their tailbone. It happens. So, and others it doesn't happen. So it just depends. A large baby and a small frame mother, that you can have a problem like that. Yeah. So but it's not. I was about to say it's not that big of a deal. I mean, it is. It is if it happens to you, but it's not a serious condition. Let me say that. Okay. Now, okay. There's the sacrum. You can see the openings there for the passage of the various nerves, and you can see the coccyx right below it. The sacrum is 5 fused vertebrae. It also is the junction with the hip bone. It forms what's known as the sacroiliac joint. We'll look at that next week. And then below that is the coccyx, which is again just a point of attachment for muscles. And while the muscles may snap the bone, the muscles are also going to keep the bone intact so that it can grow back. And there's the coccyx. And I like this one because this does let you see all the openings in the sacrum. You also see what's known as the spinous process. This section that sticks up in the middle, you see right along in here, the ridges that are sticking out. They're when you fuse the vertebrae, you're fusing the portions of the vertebrae together, but you still see the parts that are going to stick out in the back. And I'll show you more of the spinous process here in a second. Okay. This is another picture of our spinal column showing you cervical, thoracic, lumbar. This one, the sacrum, just like in real life, the coccyx usually breaks off of most of our models. So the ones that are out there that actually still have a coccyx attached are pretty unusual. I'm surprised that this skeleton still has its coccyx. Most of our skeletons, the coccyx broke off, you know, and I was very surprised to see it still there because it's sort of like reflects reality. So now the thoracic vertebrae are different than all the rest because the thoracic vertebrae have points of attachment for our ribs. None of the other vertebrae have the attachment point, but that's okay. But you can see this is the thoracic vertebrae there, and you can see the ribs there, and they still attach in the back, regardless whether they attach in the front or not, or they articulate in the back, I should say. There are the thoracic vertebrae again. 12 pairs of ribs, 12 thoracic vertebrae. Now, this is not a fish, and this is really not a good representation of what the spinal column looks like, because what's missing here are all the pads, the intervertebral pads between the vertebrae. You know, the intervertebral pads would look like this structure here in red. Right here. This red pad is an intervertebral disc, and we have them between all of our vertebrae. They cushion the vertebrae. They function as a shock absorber. When we walk, run, climb stairs, do anything using our legs, there is a certain amount of shock that's transferred up our legs, and it comes around in the front and hits a pad of cartilage in the front called the pubic symphysis. That's this structure on that skeleton that you see right here. This is the pubic symphysis here in the front. It's a pad of cartilage, and the shock of motion comes up our legs and is transferred to the front where it gets absorbed here. On the back side, it comes up, and the sacroiliac joint, which is this point right here between the sacrum and the hip bone, takes the other part, the shock of motion, and transfers it up the spinal column where it gets absorbed by all these pads of cartilage. So we don't feel, or we shouldn't feel, any kind of pain when we walk or when we use our legs for anything. We're absorbing most of that shock. Now, over time, you know, if you depending on what kind of exercises you do or the condition of your patient's backbone or their legs or whatever, or their body stature, you know, how well they've taken care of themselves, it may be very painful to move. It may not be. The things happen, but you know, an individual that maintains some level of physical activity should be able to walk and not feel any pain while they're walking. So, because that's what those pads do for us. That's not to say that it doesn't hurt, because we all end up, you know, as our patients age, they're going to have problems. You know, it just happens. Now, the reason we have this particular model here are because of these holes that the green arrows have just gone to. The green arrows are pointing at what are known as the intervertebral foramen. Remember, a foramen is an opening? Well, the intervertebral foramen are the openings between the vertebrae. Now, these foramen are not real holes. You know, we see it here in this model here. This is a very nice model. It shows you the intervertebral foramen all the way around here. What are they for? They are there to allow the passage of spinal nerves. That's what these yellow structures are on the model. These are the spinal nerves here that go, and the spinal nerves goes through those openings. They look like this, you know. Here are the intervertebral discs. there are the vertebrae, there are the foramens along in here, and on each side we have a pair of spinal nerves coming in. We have on each side, at each vertebrae, at each foramen, we have the paired spinal nerves going through here. Our spinal column that's like to bend like that, by the way. So anyway, but what we're seeing on that collection of bones there is the intervertebral foramen. They form by a nesting of the vertebrae. The vertebrae come together. One sits on top of the other. And as they sit on top of another, they form that opening. Even though there's a pad in between there, so the opening is more like that. But they nest on top of each other like this, as they're in our back, and they form this opening. And so you would see that this opening that you see when they nest together. See, one vertebrae sits on top of the other like this, and there you see the opening, the intervertebral foramen that formed from these two bones coming together right there. You don't, if you take them apart, there's no hole. You put them back together again, and you've got an opening for the, for the nerve. Back to this. Okay, now, okay. And we see the intervertebral foramen in the sacrum. Again, for the, here it's fused. These are real openings. These are real foramens in here, because these are all fused vertebrae. And, again, we're allowing the passage of nerves to go into and out of, they will go up to the bottom of the spinal cord, and they're going to bring information up to the brain and back down from the brain. So, and there's our spinous processes, those bumps I was telling you about. Yes.
So since it says foramina, it means that all of those.
Right. Yeah.
It's on this one, it only pointed to two, but that means all of those are.
Right. So foramina, I guess it's the plural version of foramen. I didn't break it, so it's only $100,000. First day we had this, they brought it in an upright position as a locked, and then they left. They said, just lower it. I couldn't figure out, I couldn't find any instructions on how to lower it. I had this thing stuck in the upright position. I thought, I had it 5 minutes, I broke it already. So fortunately, it wasn't that it was going wrong, it just weighs a lot, like 500 pounds or something. So I had to get it to come down, I had to pull down on it. So we're going to start using that very soon in lab. I had to get them to figure out how we can connect it to the screen. So, okay. Now, this is a model of a lumbar vertebrae. We have several processes on here that we'll see, and a process is nothing more than a point of attachment for muscles. So the one that sticks out the back side is called the spinous process. Some people we can see sort of little bumps on their back as the vertebrae sort of the spinous portion of the vertebrae push outward. That is this part that sticks straight up on here. So if we're looking at a vertebrae, it would be the upright portion sticking out. And so some people, we can see the little bumps on their back, where that is. Later on, when we get into bones in lecture and we talk about osteoporosis, I got some good imagery of older women who have experienced osteoporosis and their vertebrae have collapsed. They have compression fractures, and the spinous process really is pushing up against their skin. They shrink in stature because their vertebrae become very weak, and so they collapse and they bend over and they shorten. They lose several inches, and you can see the very distinct curve of their back because of that. So, and not everybody's going to get that. Not everybody's going to develop compression fractures. Not everybody with osteoporosis will have that happen. Some will. So,
Could compression fractures just happen from time, like wear and tear on the back?
well, not so much there. What happens with a compression fracture is that the calcium is leached out of the bone. So the bone becomes nothing but a shell. So that's what osteoporosis does. It allows the calcium is used up faster than it's being replaced. And so you end up with just a thin shell of itself.
Even just like a simple turn or tweak.
Exactly. I'll get you. So
That relates to mine.
a very simple thing. One of the best places for a fracture to occur in an older female patient, and I'm not picking on postmenopausal females, but those are the ones who develop osteoporosis because once they're past menopause, they're not making estrogen. Estrogen stimulates bone development. So what will happen is your bone will become just a shell of itself and it will snap. And you talked about a twist or turn, yes, or a cough or a sneeze. We can, the best place for that kind of fracture that happens very often is right here on the neck of the femur. When grandma breaks her hip, she usually breaks it right here because there's nothing left except the outer covering, the outer shell in here. Everything underneath is gone. It's like a hollow piece of chocolate. There's nothing underneath there except the outer shell. And it breaks.
And they can't really do anything for compression fractures either, can they?
Not so.
Other than
Well, there's
steroid shots.
steroid. Yeah, you can. There are therapies to.
I'm just curious. The
Yeah.
grandmother I've been talking about,
Mhm.
she's a clumsy old lady. She'll admit it. But that's what happened to her. She's always had back problems.
Mhm.
She has bulging discs.
Okay. Yeah.
Had back surgery. She's been through it. But she was making a bed. She said all I did was turn around to walk out. It was good. So I was turning around to walk back out and it just popped. So
Mhm.
right before she got sick and was in the hospital, she had went to the doctor and they were giving her a shot, whatever kind of shot it is,
Mhm.
to help with her back because of the back pain that it was causing.
Right.
And it didn't have time to activate before she got sick and was in the hospital. and all
Right.
that. So it's just kind of like,
Mhm.
I don't know, just curious.
Yeah. Well, there are drugs that will help. That will sort of tend to block the effects of osteoporosis and stimulate bone development again. And like if you break your femur, the easy fix is just to do a hip replacement because it used to be grandma would break her hip and they'd put her in a whole body cast and stick her in the bed in the hospital and she'd be dead in a week from pneumonia because she couldn't move. Now they cut the top of the bone off, put an artificial hip in there, and she's out the door in 3 or 4 days. So, yeah.
I had a very similar question on that, because I guess like how early that can set in, because one of the older people that I know, she's like 50, she's almost 60,
Mm-hmm.
and she's already like hunched, and I'm pretty sure it's starting to get like, I don't think she's went to the doctor about it yet, because she had like a car accident and she was like, it broke a bunch of bones.
Mm-hmm.
And like, I was thinking that maybe she had osteoporosis because she's hunched like that. And she's also like, her bone will break like super easy.
Well, it depends if she's past menopause,
Yeah.
then that's when the estrogen stops. Now, what osteoporosis does is your body always needs calcium. There's a constant demand for calcium for lots of things in here, and our bones are such a great source. Without the estrogen to drive the replacement, we're replacing bone, but we're not replacing it fast enough because we're always wearing it down too. And so, well, that does seem a little young for compression fractures that could be going on. It may be a result of the accident. There are conditions where we develop brittle bones, soft bones, because we are we're releasing more of the hormone that breaks down the bone to get the calcium out, to do other things with. It's not it's a little unusual to be that young to have it, but I guess a lot depends on her overall physical condition.
Yeah, I was about to say, she had like other problems too that I thought, like, she was really young too, when she got like cancer and stuff, so it was just like a lot of things when she got young. And could you like prevent that from taking like estrogen, or does that even help whenever you get past a certain point and you're not making estrogen anymore? Would you need to like have a supplement for it, or would that even help prevent it?
It wouldn't stop, it wouldn't prevent it, but it could help. I know that there is hormone replacement therapy that's available. There are a variety of drugs that will stimulate bone development, you know. So there's things that can be done. You know, it just, you would normally expect those kind of compression fractures in someone who's about 80, you know, because they gradually wear out, because, you know, you see lots of older women. You see lots of older women who are just fine, and you see some that are hunched over too. So
Yeah, like my great grandmother would still, like, up until like a couple of weeks before she passed away, was still walking like a mile a day. It was completely fine. But the other lady I know, it's just like, she has a lot of problems. I don't know.
well, with a lot of underlying conditions like that, it's hard to, you know, it's hard to try and fix a problem when you've got other problems to fix too. So,
That answers my question.
okay, good. So always feel free to ask questions. I love questions. So, okay, spinous process right there. On the sides, like wings, are the transverse processes. These are all points of attachment for muscles. We have lots of muscles that wrap ourselves around the spinal cord and spinal column here. There's the body of the vertebrae, the thick portion right here, where there's just bone, instead of living bone, but still it's thick bone, because that's where the pads are going to be between that. They're going to help to stabilize the spinal column and help to transfer the shock from pad to pad to pad. So by the time it gets up to the top of the spinal column, we don't feel it. There's our spinal cord tucked in the middle. There you've got the model over there. In fact, you can, if you want to take a look at that and then pass it around, you can see where the spinal cord is. That's about life size at the lumbar region, you know, about the size of your finger. As it goes down, it ends in a nice little point. And then we see the nerves branching out from that. There's an intervertebral disc, and this is one that is what we call prolapsed. There's a nerve there. And that red thing is called a prolapsed disc, where it's essentially blown out. What happens is that if we hurt the muscles, if we knock ourselves out of alignment a little bit, the movement, the constant motion that we have is going to put more pressure on one side of the disc than another. So if we hurt ourselves and we're sort of leaning off the side, and we stay that way, like a chronic condition, we're going to put more pressure on one side of the disc, and that's going to have less pressure on the other side. We're eventually going to see maybe that the disc is going to rupture or blow out on one side, and it's very painful. And we end up having surgery to remove the disc and fuse the vertebrae, and we can do that. It's a fairly straightforward procedure. You might lose a little flexibility, but you're going to lose a lot of pain. You're not going to have the pain anymore because of this pressure going on there.
So they remove that.
They would remove the disc because the disc is damaged. And because it's cartilage takes forever to heal because cartilage doesn't have its own blood supply. It has to get it through diffusion. And most of us can't tolerate chronic pain that long on our backs. So it's a whole lot easier to have the fusion and get rid of it. And pain goes away. And it doesn't really, if that far down in the lumbar area is where you usually have these injuries, And it doesn't really affect our flexibility a whole lot. Because, you know, these are large, powerful bones, and they can deal with that. We just don't like we don't like to live with excruciating chronic pain every day. Why should we? So, okay, now this is a thoracic vertebrae looked at from the side, and you can see a couple of structures here. The first thing you see is the body of the vertebrae. The transverse process, and this is not a great picture. The transverse process is going to be these portions that stick out to the side. This is a transverse process here and here. This bone that's sticking up is the spinous process. So we have a transverse process on each side and one spinous process just like that one. That's what we're seeing here. This is the body of the vertebrae here and here. And this is the opening for the spinal cord. That's called the vertebral foramen, right there where my pen is. And so spinous process, transverse process, they're the wings of the bone, if you will. Let's go back here. Transverse process, spinous process. Now this flat surface at the top, that's called the superior articular surface. It's sort of shaped like this, like your palms of your hand are upright. It's called superior because it's pointing up. You know, it's a flat surface facing upward. If you have a superior anything in anatomy, you got to have an inferior to go with it. And so on, if we look, we'll see right there is the inferior articular surface. So the superior articular process is in front of the transverse process. The inferior process is in front of the spinous process. What does all that mean? Well, let's take a look here. That's better. So, okay. Here is, right here, these structures right here are the superior processes, superior surface. See, there's our, for frame of reference, there's your, I'm holding it by the spinous process. Here's a transverse process. Here's the other transverse process there. And these flat areas are the superior surface. Now the inferior surface of the vertebrae in front of this, like here's another vertebrae right here. There's its superior surface there and there. There's its transverse process there and there. There's the spinous process right there. And underneath the spinous process are the inferior surfaces. And you take the inferior surface and you set it on top of the superior surface, and lo and behold, you've nested them together. I'll do it this way. So there we go. You nest them together and you end up with a foramen, because the superior surface, the inferior surface of one sets on the superior surface of the one behind it, and you end up forming a foramen. And then in the same way that if I were to switch it around and do it this way, it would work the same way. Each vertebrae has a superior surface. Each vertebrae has an inferior surface. The inferior surface will always set on top of the superior surface. So I can do it this way and have, you know, the inferior surface on this one nesting on top of the superior surface, and the vertebrae that's directly behind this one would have another one. So maybe I can make it work. It's already got something in the way. That's not gonna. How about, oh, here we go, this might work. How about this guy? How about, yeah, more or less. There, like that. They're still gonna fit together. regardless of where the vertebrae are, the vertebrae will always have a superior and an inferior surface. That's how we nest together to get these foramen that are not real foramen in the sense that they have a hole bored through there, but they form from nesting. And we have this surface ends up setting on that surface of the one below it. And that we end up with this notch becomes the true foramen. And then we have a location for the ribs. Okay, this is another thoracic vertebrae. This lets you see the body, the vertebral foramen where the spinal cord goes through. There's the spinous process. There's the transverse process on both sides. There is the superior articular process or surface, the flat area, and the inferior surface is on the other side of the spinous process. Every vertebrae has both. Okay. Okay, the last two vertebrae, the last two bones we're going to pay attention to are the cervical vertebrae, number 1 and number 2. They sit directly on top of the spinal column. They're the ones that allow the head to turn. Cervical vertebrae number 1 is called the atlas. The atlas has a couple of fossa on it so that the occipital condyles on the skull can sit right there on top. The occipital condyles set on the atlas. The atlas holds it up. That's what it does. The axis, C2, this bone here, has an axle that sticks up here. That axle allows the skull and the atlas and the skull are essentially operate together. And the atlas allows it and the skull to pivot around the axis. And that structure there that sticks up is called the dens. And you can see here, we have this is C1 highlighted in red. If you look carefully, you can see the occipital condyles resting on the atlas. And if you look, you can see the dens projecting upward into the what would be in projecting upward into the vertebral foramen in here. And here we can see there is the dens sticking up, and that is called, the whole bone is called the axis. And that allows us to pivot our head to the left and right and up and down. So when we turn our head, and when we pull on the mastoid process, we go one way or the other. This rotation around the axis is allowed thanks to the atlas C1 rotating around that structure. So there is the atlas. You can see the two flat areas here and here. The occipital condyles are going to be resting on these two small fossa here. There is the vertebral foramen. The spinal cord goes through here. We have something in C1 that we don't have anywhere else. We have a transverse foramen in our transverse processes. And then this is C2. This is the axis. There's the dens. And there's a better view of the dens right there. And it sits directly underneath C1. It allows us to turn our head. And that is the axial skeleton. So, questions on anything? Okay, well, I think we're good to go. So I will say that if you want to examine these bones at any time, I'm in here most days, every day. If the door is locked, just ask the campus police to let you in. And the bones are going to be in these boxes right underneath the anatomology. Feel free to take them out in the hall and play with them whenever you want. So